Proton pump inhibitors are one of the most commonly prescribed medications in the world, and their use has increased substantially in recent years. While these are felt to be generally effective and safe when used for appropriate indications, they're also one of the most frequently overprescribed medications. Uh, we hypothesize that patients who are started on PPIs in the intensive care unit for an appropriate indication of stress ulcer prophylaxis may have a high rate of inappropriate continuation on PPIs after they no longer have the appropriate indication for stress ulcer prophylaxis. My name is William Blackett. I am currently an advanced motility fellow at the Mayo Clinic in Rochester, and I'll be talking about a quality improvement research project I did when I was a general gastroenterology fellow at Columbia University in New York. The title of the article is Prevalent and Risk Factors for Inappropriate Continuation of Proton Pump Inhibitors After Discharge from the Intensive Care Unit, and it will be published in Mayo Clinic Proceedings. So our goal was to assess at our institution the frequency of inappropriate prescription on PPIs after ICU admission and look for risk factors for the inappropriate prescription of PPIs at discharge from the hospital. Of 24,751 patients admitted to 9 different ICUs at our 2 affiliated hospitals, just over 4,000 were started on a new PPI among patients who were not previously on a PPI. And 60% of these lacked a long-term indication for the PPI use, such as peptic ulcer disease or other upper GI bleeds, acid reflux, H. pylori treatment, or discharge on an antiplatelet or anticoagulant medication, among other common indications for long-term PPI use. We found that among these patients without a long-term PPI indication, 45% were still continued on the PPI after transfer out of the ICU to the floor, and 27% were discharged on the PPI. When we then conducted a multivariable logistic regression analysis looking at significant risk factors for being discharged on a PPI without a long-term indication, we found that patients who had had an upper endoscopy, even without any findings that would warrant a long-term PPI, such as ulcers or esophagitis or H. pylori, were more likely to be discharged on a PPI. We also found that patients who were initially admitted to the surgical ICU compared to the medical ICU were more likely to be discharged on a PPI without an indication, and that patients discharged to either a nursing home or a rehab facility compared to patients discharged home were more likely to be sent out on an unnecessary PPI. We also found that an increasing number of medications at discharge was also associated with prescription of an inappropriate PPI. The factors that were negatively associated with discharge on an inappropriate PPI were actually being intubated during the admission and being on a greater number of different floors during the hospitalization. Overall, we think that this suggests that patients who are in general sicker, who have a more complicated admission, who are not able to go home at the end of their discharge and are sent out on more meds, are more likely to get unnecessary medications. We think that the fact that patients who were intubated were less likely to be discharged on an inappropriate PPI may suggest that patients who were started on a PPI for stress ulcer prophylaxis for an indication with a clearly defined endpoint like mechanical ventilation, it's easier to stop that PPI than for patients who have a less clearly defined reason, such as severe sepsis or coagulopathy. And then we think that patients who are on a greater number of floors being less likely to receive an inappropriate PPI suggests that during each transfer between each floor, patients are required to undergo a medication reconciliation, which provides an opportunity for their providers to review their medication list and go over the appropriate indications and necessity of each medication. And so each time that's done, it provides another opportunity for providers to review and potentially cancel medication. So the more transfers actually seem to lead to a greater success in stopping these unnecessary medications. So PPIs, as I said earlier, are generally thought to be a safe medication when used for a strong appropriate indication. There have been concerns raised about possible adverse consequences of long-term PPI use, ranging from an increased risk of enteric infections such as C. diff to even a possible association with gastric cancer. Our study did not focus on evaluating the risks of PPIs, but even if the risks are low, use of unnecessary medications contributes to medical waste and increases overall healthcare costs, and can sometimes contribute to polypharmacy, leading to increased medication errors and other adverse outcomes, even if the PPIs themselves are safe. So in this quality improvement project, we focused on understanding the extent of the problem of unnecessary PPI use after intensive care unit hospitalization, with the goal of implementing additional quality improvement interventions, such as during medication reconciliations, electronic reminders to reevaluate the necessity of proton pump inhibitors, especially patients who are coming out of the ICU who may have been on them for a short-term indication such as stress ulcer prophylaxis. So patients are commonly prescribed on a whole battery of new medications during a hospitalization. It's a common time for the problem of polypharmacy to develop. And we identified that PPIs in particular are very commonly continued after an ICU admission without a clear indication. Patients should be aware, if they're discharged on a PPI, of the indication for their medication, and should talk to their doctors about whether it's needed in the long term or whether it's something that they should be able to stop. So future lines of research in this area, I think, would be to evaluate the economic costs in a national database of inappropriate PPI use to try to estimate how much actual medical waste is going into this problem, as well as to develop interventions to try to limit unnecessary PPI usage, such as reminders embedded into electronic health systems to reconsider discharge on a PPI in high-risk patients, such as those who have more than a certain number of medications, those who are going to nursing homes or rehabilitation centers, or in older patients, for example. So to summarize, we found that among patients started on a PPI in the ICU without a long-term indication, 27% were still discharged on the PPI. And we found this was most common in patients who had been in the surgical ICU, as well as patients with more complicated hospitalizations, such as a longer stay, more discharge medications, and discharge to a nursing home. We also found that patients who had undergone an endoscopy, even without any findings that warrant acid suppression, were more likely to be discharged on a PPI. We can conclude that a careful medication review should be carried out at discharge to decrease the rates of unnecessary PPI use, especially in patients who have risk factors and more complicated hospitalizations, and that gastroenterologists should take a more active role in discontinuing PPIs in patients who've had a negative endoscopy. So for further details on this paper, I would like to invite you to read our article that will be shortly published in the Mayo Clinic Proceedings.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us Our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.